I am going to present before you some notes on fungative wounds as prepared by Dr. Pooja Sadhana, Assistant Vice President, Punjab State Chapter, National Association of Palliative Care for Ayush and Integrative Medicine. Fungative wounds are very distressing for patients. The term fungative refers to a malignant process of both ulcerating and proliferative nature. Lesions that have a predominantly proliferative growth pattern may develop into a nodular fungus or cauliflower shaped lesion, whereas a lesion that is ulcerating will produce a wound with a crater like appearance. These fungating wounds may develop during the last few months of life. They are caused by infiltration of the skin by a local tumor, a recurrent or metastatic spread from a primary tumor. Sometimes a chronic wound may undergo malignant transformation to produce a fungative wound. Loss of vascularity is a major source of problem associated with these wounds. Because of the loss of tissue viability and consequent necrosis, anaerobic and aerobic bacteria proliferate in these conditions and is probably the cause of malodor and exudate that are commonly associated with these wounds. Aim of management. The ideal aim is complete healing through either local or systemic treatment, which may involve surgery, radiotherapy, hormonal manipulation or chemotherapy. Management of fungating wounds. Treatment is directed to minimize pain, infection, bleeding, odor and psychological trauma. Treatment should be realistic and acceptable to the patient and carers. The primary aim is the promotion of comfort as opposed to healing and the enhancement of quality of life which may hitherto have been severely impaired. Following assessment, choose a dressing regimen to meet the needs of the patient. Vaseline gauze or a simple dressing material which can be sterilized in a pressure cooker at home are affordable options. There are numerous commercially available products for cleaning and dressing. The simplest products may be the best and the most cost effective. The criteria are comfort, acceptability and availability. Management of malodor. Wound malodor is probably the most distressing symptom for patients and is due to bacterial infection in devitalized tissue within the wound. This can also be devastating for the patient's family and caregivers as wound malodor may be constantly detectable and can trigger gagging and vomiting reflexes. The presence of pervasive malodor can lead to embarrassment, disgust, depression and social isolation and may have a detrimental effect on sexual expression, causing relationship problems. Debridement. Malodor is usually due to breakdown of proteins in dead tissue by anaerobic bacteria. Therefore, debridement is important. The main aim of management is to kill the anaerobic organisms which are responsible for the odor formation and to filter out any malodor. Debridement removes necrotic tissue and bacteria is a primary treatment for malodorous fungating wounds. Surgical or sharp debridement, however, is not recommended because of the increased tendency of these wounds to bleed. Antibiotic therapy. Antibiotics destroy the bacteria responsible for malodor. The drug most commonly used is metronidazole. This may be given systematically, but side effects such as nausea, neuropathy and alcohol intolerance may affect patient acceptability. A poor blood supply to the wound may further reduce the effectiveness of systemic treatment. Topical preparation of metronidazole powder has been used successfully. This powder is usually applied once daily for 5 to 7 days, but may need to be repeated more often to keep malodor under control. Sugar paste and honey. Recently, sugar paste and honey has come back into use mainly due to the emergence of many antibiotic resistant strains of bacteria, and both have antibacterial and debriding properties. The higher sugar content of these products produces a hyperosmotic wound environment that inhibits bacterial growth and assists in wound debridement. Honey also contains bactericidal hydrogen peroxide, which is slowly released as the honey is diluted in wound exudates, while specific types of honey may have plant derived antibacterial properties. Activated charcoal dressings can have an immediate effect and on wound malodor. Activated charcoal acts by absorbing the volatile odor causing molecules, preventing their escape from the local wound area. Natural live yogurt. There is little research to support the use of live yogurt. It may help for wound debridement and prevent the growth of bacteria, thereby ensuring healing. It also lowers the pH of the wound environment. The yogurt is applied to the wound and left for 10 minutes, then thoroughly rinsed off and appropriate dressings applied. Management of exudates. Fungating wounds often produce excessive amounts of exudate, which can be difficult to manage. Increased permeability of blood vessels within the tumor and secretion of vascular permeability factor by tumor cells are the most likely causes of high exudate levels. Exudate production may also be increased if infection is present. Large volumes of uncontrolled exudates may cause leakage from the dressing and staining of the patient's cloth. Effective management of wound exudate is likely to improve both patient confidence and comfort. To contain and remove excess exudate, the plethora of absorbent dressings has been developed. Major categories of dressings include foams, alginates, and hydrofibers, along with super as absorbent products based on diaper technology. Pain. There are a number of mechanisms that can cause fungating wounds to be painful. The tumor, for example, may be pressing on nerves and blood vessels, or there may be exposure of the dermis. Patients often describe their pain as a superficial stinging sensation. Painful procedures such as the use of inappropriate cleansing technique or removal of a dressing which adheres to the wound bed may also have an impact on the pain experienced by the patient. Management. Analgesic drugs should be prescribed using the WHO guidelines for the control of cancer pain and in accordance with local prescribing guidelines. It may also be useful to give the patient a pre-medication before dressing change or a booster dose of their usual opioid, for example, giving oral analgesic in coordination with the dressing time. Deep pain, aching, stabbing, continuous pain. Adjust systemic analgesics. Give an extra dose of morphine half an hour before dressing. Superficial pain, burning, stinging. Local application of sensorcine, lignosine jelly or opioid soaks 10 minutes before dressing. Incidental pain occurs only on movement. Injection ketamine 0.25 mg per dose. To minimize pain during dressing, previous dressing material should be soaked and removed. Another method is the use of non-adherent dressing. Maintaining the wound in a moist environment will not only reduce dressing adherence but will also protect exposed nerve endings. Pain can be kept in check by using a dressing material that requires less frequent changes. Irrigation of the wound with warm saline rather than cleaning with a gauze swab will in some cases reduce pain. Complementary therapies can play an important part in pain management. Therapies such as relaxation, distraction, or visualization may help anxious and stressed patients who have a heightened response to pain. Chemotherapy, radiotherapy, hormone therapy, or a combination of these anti-cancer therapies may help to shrink the wound by destroying malignant cells, reducing pressure on nerves and other structures, and decreasing the area of exposed tissue. This may have a significant effect on the level of pain experienced by the patient. Bleeding. Wound bleeding is common in fungating wounds. This occurs because malignant cells erode blood vessels and may be compounded by decreased platelet count per function. Profuse spontaneous bleeding can be distressing for both patients and their carers, while damage to fragile tissues during changing of dressings may exacerbate bleeding. Management. Preventive measures are important to reduce the risk of bleeding. Using non-adherent dressings that maintain a moist environment and cleansing by irrigation rather than swabbing will reduce the risk of trauma and subsequent bleeding. Gentle removal of dressing after soaking with saline or water is a good practice. Oral antifibrinolytics such as tranexamic acid may also help. Entamicylate 250 mg TDS or QDS is another option. Sucralfate powder may also be applied to wounds with a small amount of bleeding. Topical adrenaline or tranexamic acid can also be applied, but they should only be used under medical supervision, and caution is advised as adrenaline may cause ischemic necrosis due to local vasoconstriction. Excessive uncontrolled bleeding may need referral to a surgeon for cautery or ligation. Maggots. If maggots are present, apply or flush plain turpentine into the wound with a syringe. Wait for 10 minutes. Remove maggots with the help of forceps. Repeat the dressing with turpentine for about 3 to 4 days to remove all maggots. Infection. This is usually chronic and localized. Thorough bath before dressing reduces malodor infection and washes off exudates. The wound should be cleaned with normal saline or preferably under running water. If the surrounding areas are inflamed, especially if there is spreading inflammation, antibiotics should be used. The commonest organisms grown in fungating cancerous wound and in pressure sores include coliforms, anaerobics, Staphylococcus aureus, and group G beta hemolytic streptococcus. Staphylococcus aureus is probably the commonest pathogen. Antibiotics such as ciprofloxacin, trimethoprim, or erythromycin should cover most common infections. Metronidazole may be needed for anaerobic infections. Topical metronidazole gel solution or even powdered metronidazole tablets mixed with lignocaine gel is particularly useful for eradicating the associated noxious smell. Remember that agents such as cephalosporins, which cover a wider spectrum of bacteria, increase the risk of Clostridium difficile diarrhea. Patient's comfort. By trial and error, a combination of dressings and top packing that will be most comfortable to the patient should be used. Cosmetics. Best cosmetic effect possible should be achieved in order to boost the patient's confidence. Psychological effects. Attention to detail. Ensure leak-proof, odor-proof appliances. Give necessary information. Proper explanation to lessen the sense of isolation and to enhance confidence and morale of the patients. Simple measures for wound dressing. These following tips are practiced at Jeevodaya Hospice, Chennai. Instead of commercially available gauze, used cotton sarees or any soft cloth can be made into gauze pieces and damaged parts. Gamgee parts. Colored pads have the advantage of masking the color of blood or exudates from wounds. Preparation of Vaseline gauze. Gauze can be cut into desired size, smeared with Vaseline, piled up and autoclaved or using pressure cooker. The Vaseline melts and coats the pieces uniformly. This works out much cheaper than commercially available Vaseline gauze or tule. Papaya as dressing material. Raw papaya can be cut into thin slices and placed directly on the wounds when surface is even before bandaging. If the wound surface is uneven, the central part of the raw papaya can be made into a pulp and applied as a paste on the wound. This is found to be very useful in promoting healing of bed sores along with other measures. Controlling malodor from wounds. Ayurvedic preparation. 2-3 drops of ginger grass oil having a pleasant and soothing odor is added to half a liter of water and smeared around the wound, not directly on the wound, to mask the foul odor. Few drops of ginger grass oil can be added to the water used for mopping the floors. To control the malodor for bedridden patient with rectovaginal fistula, the following measures can be tried. Place several sheets of newspaper under the bed sheet below the waist of the patient. The carbon in the newspaper is said to absorb the malodor. References. We have the following references. Thank you.